if this is your first time with us, would really love to meet you. If you can turn your camera on, that would be great. If you could put your name in the chat and anyone that you're with. There's actually two didactics today, one from me and the other one from Dr. Linda Mihalov, who is a professor at University of Washington, a clinical professor in gynecology and obstetrics. And we're very fortunate to have her. And she joined on short notice, and she has great expertise and experience. And then we're going to have just kind of an open, free-form discussion about women's brain health and the menopause transition and anything else that you'd like to talk about in this last session. So please rename yourself if the name is not reflecting who you are. Please mute yourself if you're not speaking, and when you do speak, say your name when you unmute. If you can, as I said, turn your video on, and if there's a couple folks, add the names into the chat. As we've reviewed in previous echoes, there's so many wonderful ongoing echoes from University of Washington. There's the University of Washington Traumatic Brain Injury Behavioral Health Echo, which meets on alternate Fridays, the 1st and 3rd. There's the UW Psychiatry and Addiction Echo. There's telebehavioral health training series. There's also a wonderful opportunity when you have complex patients on high-dose opioids and you're trying to care for them safely and well. You can call the consultation hotline here, as you see, the 1-844-520-PAIN. There are also CME accredited case conferences. We haven't shared this before, but there's also the psychiatry grand rounds, which are fantastic and which have a number of topics previous and upcoming around geriatric psychiatry, behavioral health. So we see here on the archive is linked, and also upcoming empowering and celebrating the mental well-being of older Latinas through prevention and health promotion, dementia-related behaviors and medication treatments with Dr. Helen Kale. So maybe put those on your calendar and watch them if you can, or asynchronously if the timing is not working for you. Okay. With any case presentation, no PHI, very HIPAA compliant. Don't reveal anything at all that could inadvertently reveal the identity of patients or family members. And as most of you know, all of the sessions are recorded and then can be accessed through our website. We're going to be sending out at the end of this session a bit of a longer survey because it's our end of year survey. So instead of being 1 minute, it's 3 minutes. And if you can, we really do value, we look at these very carefully, add comments if you have specific comments, because we want to, make this valuable. We appreciate you spending the time. We know your time is really valuable. And so we want to continue to make it relevant and to improve it over time. So in 2024, as you see in January, we have a hub member, our own hub member, Dr. Kimmy Demotta-Riley, talking about diseases causing dementia, masquerading conditions and red flags. And then we'll have Dr. Kay Rubenstein, who is a geriatric, maybe some of you know her, geriatrician, who's talking about dementia, comorbidities, and delirium risk prevention through this team-based care. Please do bring your case presentations to Sammy, either through the chat or emailing her. We want you, please, your cases are vital to the ECHO. We have CME accreditation, no financial disclosures to make today. Here's our hub team, as you see here, which is, let me just go back and say, which, is quite unusual for an ECHO in that it's a broad across many institutes, Overlake, Virginia Mason Franciscan, Providence Swedish, and the University of Washington, and supported through very collaborative work through the Dementia Action Collaborative as well. We've provided many, many hours, over 1,200 hours, instructional hours since we started in June 2020. Over 70% of the review respondents say that they would incorporate it, change their practice based on the learnings. And we're trying to continue to expand our community. So if you think a colleague may be interested, please invite them, connect them with Sammy. All right, so now I'm going to stop this share briefly and go into, give me a sec. Okay, this one. Okay, and then I'm going to talk to you now in a different capacity about, hold on. Oops, sorry. Do you see the lecture, the women's brain health? Is that what you're seeing now?
Yes.
And it's full screen?
Yes.
Okay, right on. Okay. So yes, I'm going to talk to you now about women's brain health. Thank you for this opportunity. It's a really important area in dementia care for a number of reasons that we'll dive into. So the objectives for this talk are to identify 3 contributions of sex and gender to women's Alzheimer's disease risk, to describe the common neurocognitive symptoms of the menopause transition, and really their temporality. They tend to be transient. Let's just hold that awareness. And then to summarize, in the vast majority of cases, certainly, and then summarize 3 ways that sex and gender factors can guide the building of resilience and prevention practices. So this is really from a biopsychosocial lens. So I had the opportunity a couple of months ago to give a talk, a 3-hour workshop, actually, in conjunction with a psychiatrist and a gynecologist, and around women's mental health over the lifespan. And I want to frame it in the context of the mental health challenges that are so pervasive. So there's over 1 billion people worldwide living with a mental or addiction disorder. We just have to pause with that for a moment. And then, in many cases, they're underdiagnosed due to the stigma or consequently untreated. And a lot of these aren't even taking into account gender or social determinants that are impacting mental health. I'm not going to read all of these, but certainly just to point towards the fact that women have higher rates of mental illness than men for depression, anxiety. So women are 2 to 3 times more likely to be diagnosed with mental health condition. As I said, depression, anxiety, eating disorder, trauma, and stress-related conditions. We haven't observed a difference in the incidence of bipolar or schizophrenia, but their presentation is different. Women have greater risk of intimate partner violence and sexual trauma. And as this community is very familiar, there's higher risk of dementia and age-related cognitive decline. And over the pandemic and just over time, there's been a significant increase in substance use and alcohol use, in particular in women. So, the reasons for this are really complex and multifactorial, and there's sex differences, gender differences, socioeconomic differences. And then we see certain disorders that are only seen in women. So like, premenstrual dysphoric disorder, perinatal depression, infertility, and then the menopausal issues that we're going to talk more about today. So how does, estrogen connect with stress, depression, cognition, and what are the sort of biological interactions that may undergird some of these, brain fog issues, insomnia issues, and other issues that we're going to talk about? So the systems in the brain that are affected in depression and also in cognition are sensitive to estrogen, such as limbic structures, hippocampus, amygdala, and also prefrontal cortex. And we also know that estrogen affects the stress response, emotional processes, and cognitive function. So when you have steady estrogen levels, you can have more resilience in the stress response. You can be more nimble with your emotional processing, and you can think you have better verbal memory, you have better overall problem solving. So you can manage these kind of stressors that are quite common. And then on the other side, if you have emotional dysregulation, because of these fluctuations, you're more susceptible to depression, anxiety, and brain fog. So as a result of these fluctuations, as I said, and then you're more vulnerable to the stressors. Okay. And in addition to that, and in a broader again, kind of community biopsychosocial, there's also social determinants or ethnic disparities in women's mental health. And so we really need to be very thoughtful in the kind of care that we're providing with cultural humility, so as not to kind of inadvertently intensify stress or re-traumatize people who are suffering. Furthermore, there's a very strong bidirectional interaction between mental health, cognitive health, and lifestyle behaviors. So, we as humans have this negativity bias that is evolutionarily adaptive. And at the same time, it doesn't support positive health choices. So if you have, for example, untreated depression or anxiety, you may not want to get off of the couch. You may be drawn to comfort carbohydrates or ultra-processed foods, which can increase your risk of type 2 diabetes or hyperlipidemia or stroke or obesity. You may be more inclined to use risky substances that further increase your risk down the road of dementia. It makes it harder to get out and be consistent with exercise. It may contribute further to insomnia. It may impact social connectivity, and we know that loneliness can also be really harmful to health. And as I said, it can affect stress coping or, that adherence to a kind of holistic health program. Okay. So now we're going to shift to the neuropsychiatric and cognitive health kind of approach in the menopause transition. So menopause, is a biological shift that occurs in half of the population. So it's an inevitable phase in every woman's life as the reproductive years come to an end. And it's defined by not having had a period for 12 months in a row. There's a gradual decline in fluctuations in estrogen and progesterone because of natural aging, or, if you have premature ovarian failure, or you have surgery because of a cancer, or you have certain medications. The average age is 51, and then perimenopause can last, a very long time, between 2 to 10 years. And that's when the most intense menopause symptoms tend to occur, such as the vasomotor symptoms, which can really impact sleep. And then after that year, the woman is called postmenopausal. And, we know that postmenopausal women have an increased risk of dementia and heart disease and osteoporosis. So this is just a really, I think, good picture. So normally, if you have a lot of health promoting behaviors, then this blue in the middle, kind of the foundation and grounding that you're standing on is broader, and you're less likely to have your balance tipped to make choices that promote further kind of a negative cascade of choices and health behaviors. However, if you're going through a lot of fluctuations, you may make these choices that we've been talking about: poor nutrition, not feeling like you have the energy or motivation or structure or capacity to exercise, and so forth. So it can be kind of a vicious cycle. Okay. Sorry about that. Okay, I already said this, but basically when you have menopause, the changes that happen occur about 2 decades prior to the typical age of onset for Alzheimer's disease. And we also know that these fluctuations in hormones that lead up to menopause and amyloid accumulation happen around the same time, as you see here. So 2 decades before the common presentation. We also know that decreased estrogen increases the risk of systemic inflammation. There's breakdown of the blood-brain barrier, so that can additionally lead to inflammation or neuroinflammation, and there's more vulnerability in the brain in those areas that I've spoken about earlier. We like to say at our ECHO that heart health is brain health, and I would also encourage us to think about gut health and its role in brain health. And we've had a lot of talks about food as medicine. And I just pulled this recent paper that came out with reporting an association of ultra-processed food consumption with risk of dementia. And of course, we know that these are not the gold standard of the double-blind prospective randomized clinical trial. That's just not possible with nutrition science. However, this is a prospective cohort study, and there's also a lot of other studies, which, we know what's good for the brain in terms of nutrition, and we know what's likely unhealthy for the brain. And with a healthy gut axis, it's been associated with synaptic formation. I just pulled this paper from Frontiers in Immunology, improved cognition, memory, and also mood. Okay. So this is kind of a very vivid cartoon of going through the menopause transition and having increased insulin resistance, increased leptin resistance, increased pro-inflammatory cytokines, and reduced anti-inflammatory markers, all kind of cascading to cognitive dysfunction. You see shrinkage, atrophy. And whereas there are approaches that can promote neurogenesis, improve blood flow, improved insulin sensitivity, reduced pro-inflammatory cytokines, and these have to do with some mind-body practices and also, of course, physical exercise. So as I said, to repeat, they promote neuroplasticity, neurogenesis, and these neurotrophic factors such as brain-derived neurotrophic factor, BDNF, and in particular in the hippocampus, which is this area that's vulnerable to the early changes of Alzheimer's disease, as we know. So here's just a big list of the symptoms. Not everybody has all of them, but most people, 85% or more, have some of them, and especially the vasomotor symptoms, hot flashes and night sweats. But brain fog, trouble with memory and thinking, tip of the tongue dysnomia, irritability, loss of libido, also very common. So as I said, about 85% or more of perimenopausal women will experience some physical, cognitive, or neuropsychiatric symptoms. I'm not going to name all these, but our women's brain health program was really developed in conjunction with our colleagues in gynecology to address the brain fog and some of the neuropsychiatric and sleep issues that are very common. This is a really great ongoing study of women across the nation to look at, menopause across different ethnicities. Here is a great fact sheet on how, for patients, really well written, very useful, about how menopause can affect cognition and thinking. And then there's other fact sheets. And what's useful about these is that they're in English, Spanish, and Chinese, Mandarin, I believe. So I think that's helpful. And then, menopause doesn't simply, affects a number of organ systems, right? So it can affect the brain, as we talked about around satiety. It can affect sleep by desynchronizing central and peripheral clocks. There's effects on endothelial function, effects on insulin resistance, as we talked about. So I can point you towards, if you want to do a deeper dive, to this paper as well. And then there was a recent meta-analysis by a number of scientists, researchers, including Roberta Brinton and Lisa Mosconi. Lisa Mosconi directs the Alzheimer's Prevention Clinic at Cornell. She's a psychologist and a brain imaging researcher. She's not an MD. And what they found here, and again, we don't have sufficient evidence to say that menopause hormone therapy is protective for Alzheimer's prevention. That does not exist. Studies have not been done. This is a meta-analysis that was conducted. And in this meta-analysis, for people who had estrogen only, and as you see, closer to the time of menopause, so here's the time since menopause, they had lower risks, so moderate risk reduction for estrogen only. So you don't have a uterus to have safe estrogen only treatment. Okay, the more you wait, the lower the effect, or the more neutral the effect. So is this a window of opportunity? And you may recall when we had Jessica Caldwell, who directs the Women's Alzheimer's Prevention Clinic at the Cleveland Clinic, also spoke about this window of opportunity. Okay, for estrogen and progesterone, the risk reduction was less, also seen early on. And then the risk increases over time. Okay. So we need to, thankfully, this is now starting to get destigmatized and talked about more and understood at the societal level. And there's a really great sort of decision-making tool that just came out to talk about brain fog in menopause. And what we unfortunately know is that, low and changing levels of estrogen, as I've said, really impact everything that can affect verbal memory. So, you thought block if you're anxious, you can't sleep well, you can't remember. I mean, I'm sure if we asked people to unmute themselves and say if they've had a poor night's sleep and difficulty with, word retrieval, most of you would unmute yourselves and say, yes, that's true. So we need to be careful because, it's not forcibly estrogen. There are other things that we need to consider in this transition that can impact cognition in the moment. And then, as I said, these changes typically for the menopause transition are transient. And okay, so what is brain fog of menopause? There's a definition. And, we've kind of been talking around it, but I'll just read: the constellation of cognitive symptoms experienced by women around the menopause, and it most frequently manifests as memory and attentional difficulties, this difficulty in encoding and recalling. So the tip of the tongue, the verbal memory challenges, names of people, stories, numbers, losing the train of thought, walking into a room and spacing while you're there. And of course, we're in the 21st century where we're constantly bombarded, we're not monotasking. And so there's all sorts of reasons why it is becoming more difficult to pay attention as well. All right. But broadly speaking, we know that optimal cognitive health is impacted by all of these factors. So again, heart health is brain health, and address hypertension to a systolic blood pressure of less than 120/80. That's the Sprint Mind study. If you've had a TIA or a stroke, target an LDL of less than 70. Manage diabetes, address it, treat it, prevent it if possible. Train the body to boost the brain. We'll talk a little bit more about these. These are just kind of nice synthesis. Don't start smoking, stay connected, challenge the mind, learning new things that are interesting, fun, fast-paced, and social. All right. So this hasn't yet, sort of came out in digitally, but not yet in print, where actually the NHS is taking on, I can't be dealing with this brain fog, a workplace focus group studying and investigating how can we support women, half of the workforce, right, as they're going through some of these changes. And to just take a step back and to recall that there are many overlapping factors that target brain health, which are not unique to women. So those are these modifiable risk factors that we know and recall that 40% of dementias are preventable over a lifespan. And if we get upstream in midlife or across the lifespan, then we enhance the chance that we're going to really course correct, right, or change the trajectory and promote health span. And so those are the modifiable risk factors that we've been talking about, for 3 years now, really. So that's, optimizing our lifelong learning. So low education is a risk factor. As we said, untreated hypertension, hearing loss, smoking, obesity, depression, sedentary lifestyle, diabetes, isolation, social isolation or loneliness, excessive alcohol consumption, traumatic brain injury, and air pollution. Okay. So as I said, the brain, thankfully, in the vast majority of cases, so there are things that affect brain function in menopause, in addition to fluctuations in estrogen. Age affects it, also your ApoE4 status, and your ethnicity. And these all can affect cerebral metabolic and bioenergetic processes temporarily, which have been associated with the cognitive challenges that women can experience. And so this brain fog, as I said, is multifactorial and transient, and the regions that are affected are mainly in the limbic structures and the prefrontal cortex. Okay, and thankfully, the estrogen receptors are most densely populated in, as I said, kind of the medial temporal regions and the prefrontal cortex, in similar areas which are affected and boosted by certain health behaviors. So, for example, when you exercise and promote BDNF, you can target these areas that are vulnerable in the brain to the fluctuations in estrogen or the drops in estrogen that happen in the menopause transition. So this is kind of repeating a little bit what we've said, but women, you know, not only are they vulnerable to depression more than men, but there's a certain stage. So 45 to 55, they're 4 times more likely to have depression than women who've not yet reached that stage in life. And so it's not just hormonal fluctuations, it's also all these other things that can, you know, the vasomotor symptoms, the insomnia, aging, being sandwiched between caring for children and your aging parent who may or may not have dementia themselves, and many other factors. So we know to define, you know, depression, feeling depressed nearly or 2 weeks or more, feeling sad or empty, anhedonic, and so forth. Okay. So people may be familiar with this slide, which Jessica Caldwell shared, but you know, women have these different, the ApoE status affects women differently than men, which I'll talk about in a moment, and then stress as well. 2 out of 3 people are in America with Alzheimer's disease are women, as we know, and 2 out of 3 care partners are also women. And you know, acute stress can be really good and hormetic stress can be very health promoting, but chronic stress is really neurotoxic. So the response to stress differs by sex, the immediate and prolonged response, and it affects memory because it's neurotoxic to the hippocampus, or the structure that is important for encoding of memory. And then it, as I said, it promotes cell death in the hippocampus and increases the risk as a result for Alzheimer's disease. We remember from, you know, way back the HPA axis, going from the hypothalamus down to the adrenals, releasing cortisol, and, you know, stimulating this fight, flight, or freeze. And in that phase of elevated blood pressure and rapid breathing and more muscle tension, it's very hard to intentionally focus our attention, very, very hard. So if we're in that dysregulated nervous system, it's really hard to recall information or to retrieve information or to problem solve. So Herb Benson was a cardiologist at Harvard who coined the phrase the relaxation response. This is kind of how do you shift your nervous system into a place of greater ease. And so it can be very useful and helpful with patients and families to help them to learn these practices that can promote, you know, that can engage the parasympathetic branch of the autonomic nervous system and improve focus, lower blood pressure, and so forth. So in our 3-hour workshop that we had, I then added a little movement break. I don't know if you guys have been sitting, but you know, in the morning, or what kind of stresses you had, but you may want to just get it going, refocus your attention, move around a little bit, maybe have a sip of water. Okay. So, you know, stress is unavoidable, but toxic chronic stress, as we've been talking about, can really be harmful and can promote accelerated aging. But what would this ideal dose be over the lifespan? And Alyssa Epple, who's a stress scientist at UCSF, has this diagram. And we know that we need to kind of continue to grow and challenge ourselves to stay healthy and well. And that's true in all domains, not, you know, in cognitive resilience and physical resilience. Strength training is very important. And what happens for women is that they have sarcopenic obesity vulnerability in menopause. So women tend to put on weight and lose muscle, which of course increases their frailty and fall risk over time as well, if they don't incorporate approaches to counter that biological change. So we know that strength training, for example, lowers insulin more than any type of exercise. It increases that lean muscle mass. For people who are breast cancer survivors, it can help with lymphedema and strengthen mobility after treatment. And it can improve quality of life because it combats frailty or promotes strength and reduces the risk of falls and fractures, as I said. Okay, it promotes independence. I think I've shared these previously, but basically, and I'm not going to read them all, but movement is medicine. Okay. This was a huge study of many, I think over hundreds of thousands of women in Scandinavian country, I think in Sweden, and they were followed, 44 years, right? Which is impossible in America, but with social medicine and in Scandinavia. So the women who were pretty active in midlife, cardiovascular fitness was associated with reduced dementia risk. And this is one of the strongest sort of longitudinal studies that we have, which focused on women. So how do we do it? How do we talk to patients to motivate them? Because information wouldn't be sufficient. So, small little exercise snacks can be useful or helpful. Little small strength, maybe with a band first to kind of get you confident. And it can help also to focus your attention after exercise, as we know, and help with memory after exercise. So doing exercise during the day can also really help with cognitive function throughout the day. And it's a mood boost. So what are the guidelines from the American College of Sports Medicine? This should be familiar to most of you, but I'll just, highlight them or underscore them if you haven't reviewed them for a while. So, 150 minutes of moderate intensity exercise or 75 of high intensity per week, which is really about 30 minutes, 5 days a week. You can do it in 10-minute boosts, instant recess type approaches, doesn't really matter. And then resistance exercise 2 to 3 days a week. And then it's very important to do some stretching and also some balance training as well. Okay. So this review came out not that long ago, as you see. And so menopause hormone therapy is effective for a number of symptoms of the menopause transition, namely vasomotor symptoms or genitourinary syndrome. But this cannot be used in folks who have estrogen dependent cancer, or they have blood clots or complicated migraine or history of stroke or family history of breast cancer or BRCA gene. So there's a lot of people who cannot use menopause hormone therapy, even for the symptoms for which it's been approved, including, as I said, the vasomotor and genitourinary. Cognitive behavioral therapy can be really effective for depression and anxiety. And then there was this new neurokinin 3 receptor antagonist called Veozah or fezolinetant, which is indicated for the treatment of moderate to severe vasomotor symptoms of menopause. It was just approved this year. There are other medications that are familiar to you all that can be used and have been used. I would recommend or counsel that we avoid paroxetine because, of course, there's anticholinergic effects with paroxetine, so it can worsen the brain fog. But you could use gabapentin or low-dose SRI or Effexor. And then there are other things like sleeping in a cold room and some other approaches to minimizing your alcohol, because alcohol can trigger other triggers. So we've been talking quite a lot about stress, and mindfulness approaches can be very helpful as well. So there's been, this could be a talk in and of itself, of course, but that meditation has been demonstrated to help with managing of, lowering cortisol and inflammatory markers and lowering blood pressure and improving that concentration, as we've been talking about. And additionally, really helping with that self-regard, so that negativity bias can really be countered through some simple, quick, brief practices that can be taught, whether in a group context or in the office, that can be useful during this time of challenge and accelerated aging. I mentioned Alyssa Epple earlier. This is her book that just came out this year. That's a really readable, concise, science-based book about managing stress. And then there was a study from the other university of the other UW, or the University of Wisconsin, Richie Davidson's group, where they looked at, during the pandemic, a 4-week app-based stress intervention. That's the Healthy Minds program. And there were improvements in well-being. And these were primarily women, actually, who were teachers, as it were. And then there's also a study demonstrating that some health coaching. So really kind of helping to support women who are going through this, biological shift. So how do we do that? Well, we want to ask about, what are your symptoms? How are you feeling? Have community resources at the ready, and then use the evidence and what we have at hand. Destigmatizing and cultivating communities of belonging and support can also be really useful and helpful. And we'll talk about that in a moment. So namely, so when we are offering we try to leverage the virtual shared medical appointment for these people, and it can really help to improve access. People have more time to talk about their concerns or have their questions answered. But I would say the most salient feature of these that I have witnessed in facilitating these medical appointments is the peer-to-peer support, connection, and learning. So there's accountability and support as a result. And we incorporate approaches like motivational interviewing and SMART goals and the behavior change science to help people to kind of promote these health behaviors that we know can optimize health in midlife and also really confront or mitigate the risk. Okay. That said, we still want to keep in mind always, what is our cognitive checklist? Could there be a micronutrient deficiency? Is there an endocrine problem? Are there other routine contributing factors? Is there an unknown yet and substance use challenge? Is the person depressed? Are they taking things like, Tylenol PM or benzodiazepines or Ambien? So really being thorough in the approach when somebody's telling you, gosh, I have brain fog in my 50s. What's happening? Might they have untreated sleep apnea or hearing loss or, any perceptual processing challenge? And then if it's appropriate, we could consider imaging, such as an MRI with hippocampal volumetrics. I would say that in most cases of these women that we're seeing in the Women's Brain Health Program in perimenopause or with a family history of Alzheimer's disease, in the majority, I would say imaging is not indicated, though in some cases, of course, it is. So then, what's the brain health prescription? We look at deprescribing or avoiding sedating or anticholinergic medications. And there's a whole anticholinergic medication list that we've posted in previous talks, addressing and treating contributing conditions. We talked about the exercise component and other stress resilience approaches. And then the importance of cognitive and social engagement, nutrition. Optimizing blood pressure in midlife is probably the strongest lever that we have, frankly, and really keeping that systolic below 120. There's loads of studies looking at even brain, atrophy in the brain, cognitive function for people with the sprint mind. There was a benefit for MCI, not for dementia. It may not have been powered. We're looking at that. It's still ongoing. Okay, and so just to sum up, women's risks, this is a paper that I wrote with Jessica Caldwell. It came out this year. Women's risks for poor brain aging, of course, are similar to men, and then they're very different as well, which we've talked about. And that these interventions that support healthy aging have to consider, the broader context, the biopsychosocial context of women's health. And women tend to have better verbal memories, so we maybe need to come up with more stringent, assessments because they tend to do better, and so then tend to be diagnosed later. And then to really incorporate these additional approaches around education, destigmatizing menopause, validating their experience. The brain fog is real, and then menopause is a risk factor for dementia. And, these other things are contributing, as we discussed. We don't have sufficient evidence to recommend at this point in time menopause hormone therapy for the treatment of, for Alzheimer's prevention. We do not have that sufficient data. And then, with regard to the ApoE, this is really complicated, and I think we're learning more. So apolipoprotein E, as people know, if you have a copy of the 4 allele, your risk is increased. And we had Sumi Jayadev on our echo, and she really doesn't recommend testing ApoE4. It's that we know we can moderate that susceptibility risk. We know, in other words, based on our behavior and the environment, we can change that gene expression. There's epigenetic modification of that risk. However, it affects women differently. So if you have 1 copy of the ApoE4 compared to a white man, your risk is 4 times. If you have 2 copies, yours is 10 times, and you tend to get it earlier. So it shifts the curve to earlier. However, this association differs based on ancestry. So the greatest effect has been seen in East Asian, and then non-Hispanic whites, and then non-Hispanic blacks, and then Hispanic individuals. So as I said, the ApoE4 susceptibility risk for having a copy of the ApoE, the 4 is different. Then we think, is there a window of opportunity, as I highlighted, around when you should treat? we know that there's a clear benefit for people who are, women who had early menopause, like surgical menopause or premature ovarian failure. But we know also that with the Women's Health Initiative, it was initiated after 65, it was really negative outcomes. So thinking about what would that key time be? So it's not recommended for prevention. We want to personalize this based on age, menopause stage, comorbidities, and symptoms. And then we need to learn more about, gender affirming hormone therapy and long-term cognitive health. This is an area of like emerging science, I would say. So it's a conversation, and Dr. Mihalov, who's going to speak next, has tremendous experience in this area. This, as I said, is our Women's Brain Health Program. We started in August of 2022. We have some exciting research that I'm embarking on that I'll share maybe at a later date. We're at this at our Center for Healthy Aging, and we have a bunch of different collaborations as well. Dr. Mihalov, who's a clinical professor in obstetrics and gynecology at the University of Washington, and is also certified through the Menopause Society. So thanks for joining us, Linda. She's a dear colleague, and please, begin. Can you unmute yourself, please? Can't hear you yet.
Oh, brother. Now can you hear me? I just gave my whole lecture while I was muted. Never mind. I apologize for that. Yes, so I was saying that I have worked at a couple other places in Seattle, most recently at Virginia Mason. I've been back at the university for 2.5 years and do a lot of general gynecology, but I have a special interest in menopause, and I've been a certified menopause practitioner by the North American Menopause Society since about 2006. And I can tell you that every year at our annual meeting, the brain and cognition is a very hot topic. So even though our randomized controlled trial data may be somewhat lacking in this regard, it is very, very interesting to a lot of us. And what I'd like to do is talk sort of more about the clinical aspects. Nancy did a beautiful job of talking about the biophysiology, but let's talk about the clinical aspects. So could I have the next slide, or am I advancing my slides? Okay, so how do we diagnose menopause as the cause of the symptoms? We are doing that clinically based on the age and menstrual status. If someone has had a hysterectomy, that makes it harder to figure out when cycles have stopped. We don't have, there's no threshold FSH or estradiol level that would say, aha, this is menopause. So you just have to judge based on what's going on clinically. And many women, and by the way, I'd like to say that the language that I used and the language in all of these papers uses the term women, but not everybody who has these issues identifies as women. There is no specific hormone level that's going to make that definition, and it can be different for everyone. We need to, when a woman comes in with a complaint of menopause as a cause of brain fog, which is a very common report, we kind of have to do a diagnosis of exclusion and either identify or optimize those other factors. If there's a hormonal imbalance that's happening in the perimenopause, a lot of times if we correct that imbalance, then we can smooth things out. So Dr. Isenberg showed a slide that had estrogen and progesterone levels going like this up until the time of menopause, and then they're stable. But around the time of menopause, those hormone levels can be even more erratic, and that can cause a lot of symptoms, both physical symptoms like breast soreness and irregular cycles, as well as more cognitive effects. Because vasomotor symptoms can be contributing to cognitive symptoms, we can treat the vasomotor symptoms directly. There are several non-hormonal approaches including the fezolinetant or Veoza that Nancy was just talking about. This is a great advance for us. Naturally, it's quite expensive because it's brand new, but I have had people whose insurance has covered it. We don't have any clear evidence that improvement in hot flashes improves cognition, but it does improve how people feel and quality of life. Next slide. So the clinical, let's see, let's go back to the next one, the one you were on. There are multiple clinical factors that we discussed that have that can affect cognitive function in menopause, such as sleep. And sleep can be affected by the same process that's going on in the brain that is causing the hot flashes, which are those candy neurons, kisspeptin. These are the new discoveries that have led to the treatment, a new non-hormonal treatment. Mood obviously can have a big impact with an increase in depression and anxiety. Family pressures, as we discussed, and situational stress can contribute. And age at menopause can also be important. It's really important for women who go through menopause at a very young age. Premature would be under 40, early would be between 40 and 45, to consider whether or not they need or should benefit from hormone therapy, because long-term consequences start that early, or can start that early. The vasomotor symptoms of menopause, as we discussed, hot flashes and night sweats, all of these things can be directly affecting cognitive function. And when the patient is in front of you, you're basically trying to figure out which one of these things is the most important and which one of these things is that has to do with what's most important to the patient, of course, not necessarily to us, but as far as the patient is concerned. Next slide. So these, we talked pretty much, let's see. Yeah, we've talked already about those cognitive changes. These slides, some of these slides are from the North American Menopause Society position statement on menopausal hormone therapy, which is very valuable. So I would direct you to the website menopause.org, where the NAMS, now the Menopause Society, has multiple position statements. They just have one from 2023 on non-hormonal treatments for vasomotor or other menopausal symptoms. So these things we've already talked about, the general health benefits. Unfortunately, we have tried, even for vasomotor symptoms, randomized trials looking at botanicals and herbal supplements have failed to show any significant benefit. So the thing that really works the best for vasomotor symptoms is estrogen. So kind of our decision process in many patients is first, is this patient a candidate for estrogen or not? Next slide. So in the trials, hormone therapy has a small to no overall effect on short-term or long-term cognition, which is always surprising, because those of us who talk to patients all day hear that it really makes a difference for them. The timing of administration, and I'll show you in the next slide, doesn't really show a significant different effect. But women who undergo surgical menopause who start hormone therapy may benefit from improved cognitive skills, such as verbal memory, at least in the short term. And there are people in our field. I was just listening to a podcast from Dr. Walter Roca from the Mayo Clinic, who's a neurologist, who has been a big champion for protecting the brain health of younger, especially younger women who have had surgical menopause at a young age and really suffer a lot of consequences that people aren't paying attention to early enough. So he's a big fan of keeping the ovaries in as long as possible. But if they have to come out, replacing estrogen, even in women who carry a high-risk mutation, a BRCA mutation, if they undergo risk-reducing surgery, they are still considered good candidates for estrogen replacement. Next slide. So these are some of the trials. The KEEPS trial, the early prevention trial, showed no cognitive benefit or harm from oral or transdermal estrogen. The WHI memory study of younger women found no sustained benefit or risk from oral estrogen. And you'll recall, I'm sorry, that should have been women aged 50 to 55. You'll recall that the Women's Health Initiative, which came out in 2002, and last count has produced more than 4,400 papers, and they are still studying these women and looking at this data. That included women who were average age 63 at randomization. So that was definitely an older cohort, but they did have a smaller cohort of younger women that they followed. The WIMS memory study down at the bottom, in women over 65, the risk of dementia was doubled for women who used estrogen and progestin, but not those on estrogen alone. But basically, that was the data from the WIMS trial that caused the FDA to put dementia in the black box warning on every single hormone, every single estrogen product. Yes. And that also speaks to the window of opportunity theory that we really are best off with hormone therapy around the time of menopause, within 10 years of the menopausal transition, which doesn't mean 10 years after age 51. If a woman starts her menopausal transition at 45, you've got 10 years from that. If she doesn't start even missing a period or having any symptoms till age 55, you've got a little bit longer there. Recognizing that probably women who are older when they started on the hormone therapy had already developed atherosclerosis that was negatively affected by the hormone therapy. There was a small clinical trial that showed cognitive benefits of estrogen in women who had moderate to severe symptoms, but basically we don't have clear data that that treating vasomotor symptoms improves cognition, although it seems like it would, right? Not scientific, but it seems like it would, and people describe it that way. Next slide. So again, what about younger women? This is sort of one of my pet peeves, is that women who undergo surgical menopause are often have an idea that it's not safe for them to take hormones, or they don't need them. And if they don't have vasomotor symptoms, they think that they don't need them. But the risks are much lower in them. And the way I think of it is that the majority of women are entitled or intended to have estrogen in their system until they get to be around 50. So a woman who has had a hysterectomy and her ovaries removed at 35 is entitled to have estrogen. That's what makes what her body is reliant upon. And it's important for mitigating multiple risks, including bone loss, sexual function, and heart disease. And Dr. Roca just published a new paper on renal function. So chronic renal disease affected by estrogen deficiency in oophorectomized women. Next slide. So these are the current recommended hormone regimens. And if you look at the NAM's position statement on hormone therapy. These are the kinds of things that you will see. Transdermal estradiol, we consider the safest formulation. This is not what was in the Women's Health Initiative. That was essentially Premarin and Provera, medroxyprogesterone acetate oral. So these days we prefer transdermal because it's not been associated with an increased risk of stroke. And it's a nice stable level over the course of the day for most women. We most commonly use oral micronized progesterone. The progestins are difficult molecules to get into the body. Estrogen is easy. You can put it on the skin and the vagina. You can put it, you can take it orally. You can use a spray that goes on the skin. Estrogen is easy to get in. Progesterone is not so easy, but it's critically important for people who still have a uterus. If there's no uterus, there's no need for the progesterone. There's no advantage to it. It doesn't provide any clinical benefit. There are some women who have who benefit from progesterone, especially micronized progesterone, for sleep. So we do recommend taking it at bedtime on an empty stomach because that can be beneficial for sleep. The intrauterine progestin in the form of an IUD, such as Mirena, is popular, but it's not FDA approved for this indication, and I don't know if it ever will be, but it is the most satisfying because it delivers the progestin to the only place in the body that needs it, which is inside the uterus. Unfortunately, or fortunately, there's no data to support any particular regimen for cognitive effects. So if you believe, like I do, that it's beneficial for cognition to take hormone therapy, then I can choose for my patients the regimen that works best for them, whatever that might turn out to be. And sometimes there's a lot of trial and error. How long should we use it? Well, that's a good question. We basically go through a shared decision-making process every year with an annual review of the benefits and risks. The position statement of NAM says that there is no reason to withdraw hormone therapy from someone who feels that they continue to need it. The technical labeling says that estrogen should be used for the shortest duration, at the lowest dose and the shortest duration. But most people who believe in these benefits don't see any compelling reason to stop it at any particular age. Next, I think that may be my last slide. Yes, that was my last slide. So I would love to hear questions or comments.
Thank you so much for that fantastic talk. And I see Erica's hand is up.
Hi, I have a question for either one of you, and wondering if there is any research on the benefits or drawbacks of women or people who have had pregnancies versus non-pregnancies, and their effects on estrogen levels or dementia.
I don't think I've ever seen that breakdown. Have you, Nancy?
No, I'm just thinking, I mean, I think I've seen a couple of, I think that it's not definitive or convincing. I mean, I think there's some, yeah, no.
And my personal experience is that I would like to think that you could predict someone who had horrible premenstrual disorder or horrible pregnancy problems would likely to have somebody who's going to have trouble with menopause, but it doesn't, I don't think it correlates. I think that you don't know what's going to happen to you until you get there. And it may or may not be just like other people in your family. So and sometimes people will ask me, how can I prepare for menopause? Well, the best way to prepare for menopause is to do all those things Nancy said about taking good care of yourself, exercising, eating well, because that gives you the healthiest body going into it. But there isn't really any other way that I know of to prepare yourself except for that.
I totally agree with you. And I think I would just add one more thing, which you kind of pointed towards, but I would just call out, which is that a lot of people have this belief that they're their mom or they're their genes. And I think that naming that can be very helpful, that they're not their parent, they're not their gene. And that in most cases, I mean, the single greatest risk factor, as we all know, for Alzheimer's disease is advancing age. And then there are all these modifiable factors that we can address. And so really naming that for people, particularly if they are caring for their parent with Alzheimer's disease, it's not to say that they don't face a risk, but that that's not forcibly their trajectory, can be really useful. Because as we've learned here again, the way that you look towards the future and see yourself aging is really important to the choices that you're making in the day-to-day and that long-term risk as well. That kind of meta component when you're talking to folks in the room about their concerns, acknowledging it and then supporting them in that way. Sylvia.
Yes, thank you both for the lectures. They're really helpful because there is always a little bit of uncertainty when it comes to this. I have two questions. One is, what is your approach when you're seeing somebody who has vascular risk factors and trying to determine, I might have missed the first part, sorry if you already said this, but how do you consider this? Because I get the question a lot. I've had a stroke or a TIA, or I have had a heart attack, and what do you do then? And then the second question, which may be a little bit more uncommon, but what if a woman who has a diagnosis of Alzheimer's disease comes needing, help from hormonal replacement therapy, whether it's for a local issue, which is easier, or more a general issue, like persistent menopausal symptoms that sometimes I hear last for quite a bit of time. And so they sometimes come to me as a neurologist saying, what should I do? And there's a big question mark in front of my face. So I don't know what you do in clinical practice, or if you have any trips or tips for me. Thank you.
What was the first part of the question again?
First one is for people who have stroke or heart attacks or cardiovascular risk factors and estrogen.
I would be a little reluctant to prescribe estrogen therapy for somebody who had already had a stroke or a heart attack. But the most recent data on stroke risk, now the stroke was higher in the Women's Health Initiative. So in the women who took estrogen, especially the women who took estrogen plus progesterone who still had a uterus. So, and that was oral therapy, but we feel a lot safer about transdermal estradiol. And I think that it's, it all comes down to quality of life. So if a woman says, I can't, I was doing fine on my estrogen, and then you took it away, and I'm a judge and I can't think anymore at work, or I'm, I can't, whatever the functioning thing isn't happening, then we can talk about what is the lowest dose. The progestin component would give me pause, because we have concern that the progestogen component is what contribute to the slightly elevated breast cancer risk with combination therapy, and also probably to some of the growth thrombotic risk. So I would try to stay away from the progestin component. But and the second part was if somebody already had Alzheimer's. So if someone had a diagnosis of Alzheimer's and they were just going into menopause, they probably have, worse problems than their vasomotor symptoms at age 50. But I don't think that would be I wouldn't consider that a contraindication as long as it was not a vascular dementia thing. And sometimes people, it makes it easier to deal with other issues when you don't have to, when you can sleep well and you don't have to worry about being interrupted multiple times a day with disruptive hot flashes. So that sounds like a simplistic answer, but there, you know, obviously with the patient in front of you, there's a lot of nuance involved.
Thank you
And-
so much.
And by the way, let me just say that a family history of breast cancer is not considered a priori a contraindication to estrogen therapy. So somebody who has a mother who had breast cancer when she was 70 or something like that, that's not considered a contraindication to starting it at age 50. It's an important thing to bring into the picture, and also parenthetically to think about, is this someone who needs genetic testing? That's another lecture.
So I have a follow-up question for you, Linda, in that patient, for example, maybe who had a stroke, but who was having really debilitating, who was working as couldn't work as a judge, or he was really debilitated. Would you maybe do unopposed estrogen and would you follow with uterine? Like, how would you?
Yeah, that's a good question. In somebody, the particulars of how I would do this in someone like that is I would use the lowest dose and assess symptom relief, and then gradually move up. And I would start with estrogen alone.
Mm-hmm.
The way we do it typically is we start with estrogen by itself. I mean, we start with estrogen and progesterone because we tell patients, this is how you're going to do it. You have a uterus, this is how we do it. And so most people, we start that way. But in point of fact, it would take several years for unopposed estrogen to increase the risk of endometrial hyperplasia or malignancy. So you have some time to work with it. And in people who have a lot of emotional symptoms or what do I want to say? They're very much affected by their emotional mood lability, that sort of thing, especially if they've had side effects from hormonal treatments in the past. I often will start with estrogen alone because it may be difficult if you start two things at the same time, both of which have the potential to cause some mood side effects. It may be hard to tell what's doing what. So in those cases, I may start with estrogen alone, make sure there's symptom relief, and we know the dosage that works for symptom relief, and then we can add the progesterone in. It sort of depends on the circumstance. If somebody really needs the sleep help, it's good to start the progesterone at the beginning because that may help with sleep, but it depends on the circumstance. And in terms of dosage use, I don't know what kind of detail you'd like to hear, but I usually start with a sort of a medium dose of transdermal estradiol 0.05 milligrams twice a week in the patch. And that gives us, there's 2 doses higher than that, there's 2 doses lower than that. So it gives us places to go with the dosage. And we can always come down. I like to use a dosage that is actually going to make a difference, because if you start with a measly little dose, they may not, people will get discouraged. It's like, this didn't work for me. Well, it wasn't enough. You needed more. So it's good to start with a dose that you think is going to be effective, and then you can always adjust from there.
Hi, Trang.
Hi, excellent. From both of you, thank you so much. I learned a lot. I have a question. I have patients in the 80s still complaining that they have hot flashes. And they said they reported that they started menopause about 20 or 25 years ago. How common is that to continue to have hot flashes and 20 or 25 years later?
Unfortunately, it's not uncommon, and I don't doubt that that's exactly what's happening. One of the things that came out of the SWAN trial, the study of women's health across the nation, is that when they have women actually chart on a daily electronic diary their symptoms, you won't like this, but they find out that menopausal symptoms start a lot earlier than we thought, and they last longer. So we used to say when you know, the teaching used to be, how long do hot flashes last? Oh, 6 months to 2 years. It's probably considerably longer than that. So it doesn't surprise me if there are people who say that they still have hot flashes in their 80s. I certainly wouldn't start someone like that on estrogen therapy. And would a drug that works very specifically on the neurons in the brain work for that? Maybe, but the population of people who were studied in the pivotal trials to get that drug on the market did not include, I'm pretty sure it did not include women in their 80s who had never had treatment before. So, nor did it, unfortunately, include women with a history of breast cancer or women on hormonal medications like tamoxifen or aromatase inhibitors, who are the population of people that I would like to prescribe it for, because those are a lot of the patients I see. And I just go through an explanation about the drug and what we know and what we don't know about it. And some people are choosing to try it and some aren't. And I'm very hopeful that someone, if I was younger and had more energy, I would run a study in that population of women over at the Hutch, because I think it's really important. It's going to be an important modality, and I think it's probably going to turn out to be fine for people with breast cancer histories, because it's not a hormone. It doesn't have anything to do with estrogen, and it's just the first of this new class of drugs, these candy neuron inhibitors. So there will be others besides this one. Just the first one that made it to the market.
Has it been helpful for your patients? Do you have a sense?
Yes. You know, the data, it's not as, the data from the studies was not as good as estrogen.
Mm-hmm.
And you're aware that any study of hot flashes has a significant placebo effect. So, you know, it's hard to know, but it definitely was clinically significant, statistically significant to get it approved. And maybe just since we have the opportunity, I can just put in my plug for vaginal estrogen. I'm a huge fan. Women who have only vasomotor symptoms, women who have only vaginal symptoms, really everyone benefits from vaginal estrogen. Reduces the risk of UTIs in older women, improves sexual function. It just, you know, there aren't very many parts of the body that can age backwards, but the vagina can. You give an older vagina estrogen and it looks young again. It's amazing. And it's not associated with an increased risk of breast cancer recurrence in women who've had breast cancer or currently being treated. My colleagues in breast oncology at the Hutch are, except for one person, very comfortable with their patients using it. So big fan.
Yeah, thank you for sharing that. And it's so relevant for our patients who we, you know, how many of us have seen somebody with the UTI, living with moderate stage dementia, coming in with delirium? I mean, it's really important. And this is a known effective treatment for these women. So if there isn't a last pressing question, I would like to express gratitude to Dr. Linda Mihalov for her outstanding talk and for this really rich discussion with all of you. And in the chat, Sammy has popped the end of year survey. So please do fill that out, take some time. And then we'll see you all January 12th for Dr. Kim Minamoto-Riley's talk.
Thank you so much, folks. I appreciate you coming on a Friday.
Thanks, everyone.